Good morning, everyone. Welcome to the Health Disparity Interest Group and NIMHD Division of Intramural Research lecture. This is Kelvin Choi, Senior Investigator at the Division of Intramural Research at the National Institute of Minority Health and Health Disparity. Once again, welcome all of you for joining us. I know we have well over 100 people. I think last count is close to 200. So very much appreciate every one of you tuning in. Before we start the presentation, I have a few housekeeping issues I want to go over with you all. First is that we actually have a new website. This is the link for the Health Disparity Interest Group. It's hosted under NIMHD website. It's open to the public, so you can come here and look at what we do. And one of the things that we have on the website is the recording of previous lectures. So for example, in February, we had Dr. Chairman James gave a lecture titled "To Race with the World," talking about John Henry and Son. And so we have the recording up there. If you guys missed it in February and you want to go there and have an encore presentation, you can feel free and go there and watch it. And today's presentation will be recorded, and so that we can, and we will post the recording at this website after the lecture. So stay tuned, and of course, if you want to stay up to date with the activity of the Health Disparity Interest Group, you can always sign up with the listserv. And how you do that is to go to the OIR website, which is also updated. And in the middle of the page, you see there's a mailing list that you can actually click there, and then it will walk you through how to subscribe to the listserv. So let's go to our speaker today. So our speaker today is Dr. Gilbert C. We're very, very fortunate to have him today to be our speakers. Dr. Gilbert C's research examines how racism and other forms of structural disadvantage contribute to the health and healthcare disparity. He examines stress, neighborhoods, and environmental justice using a multi-level and life course perspective. Dr. G's work also examined the health of Asian American and Pacific Islander, and he has served as the program chair for the Asian and Pacific Islander Caucus of the American Public Health Association. He's now, of course, a professor in the Department of Community Health Science at the Fielding School of Public Health at the University of California, Los Angeles. He holds a Bachelor's of Arts in Neuroscience from Oberlin College, a doctorate in Social and Behavioral Sciences from the Johns Hopkins University School of Public Health, and postdoctoral training in sociology from Indiana University. So without further ado, one last thing that I want to make sure that you all help us with is that if you can turn off your microphone and your camera during the presentation. And if you have questions, feel free to post it on the chat and we'll get to them after the presentation. Thanks everyone for your cooperation. And with that, I'm going to turn it over to Dr. G.
Good morning. Can you hear me?
Yes.
All right. So it's a real pleasure to be here this morning and to join with all of you and to share a few thoughts regarding structural racism. Apologize in advance if I sound a little nasally. I think I picked up a cold. Hopefully it's not Delta. So if there's a little bit of a cough or something, that you just have to excuse that. So one of my main goals for today is to really distinguish between this idea of structural racism and institutional racism. And these are terms that people have been tossing around quite a bit this past year. I've been working in this space since my dissertation, so over 20 years, and it's really amazing to me to see where the conversation has gone so dramatically, actually over the last year and a half. If you go back just to 1999, how many people were saying racism is a public health crisis? It was only a handful of people, but now there's certainly a lot more people who are interested in this very idea. And for many of us, we're very interested in health equity, reducing health disparities, and so forth. And as you know, this is part of our mission for the work that many of us do. And in the words of Healthy People 2030, achieving health equity requires societal efforts to address these inequalities, but as importantly, to address the historical and contemporary injustices in order to achieve them. And to get to the point, as Paula Braveman has said, for example, equity means social justice. And when we talk about social justice and race in the United States, we have to confront the legacy and continuing manifestation of racism in the United States. This idea of thinking about racism at multiple levels is one that I've been very interested in, and it's certainly not new. So for example, in the 60s, Carmichael and Hamilton wrote about this in their famous book, Black Power. Now, there's been a lot of discussion about things like microaggressions and hate crimes, and certainly those are really important. A single hate crime is one too many. Many of us face microaggressions in our very workplaces. But I would posit that while these are certainly important and deserving of more research, in some ways they are just the tip of the iceberg. And what sits beneath the surface is the structural racism that we all face. And I believe that it's not until we really start to address the structural racism that's harder to see, more immutable, that we will actually make some progress in eliminating health inequalities. And this multi-level view of understanding race and racism follows a multi-level view that we have, from all these various ecological frameworks that we have, like Bronfenbrenner's, way of thinking about the world, where we have, varying levels at the micro, exo, macro level, as an example. So to prove this idea a little bit further about thinking about these injustices, we can look at some data. And so here is a graph from some work by Doug Almond. He's an economist. And what you have here is a graph that looks at post-neonatal infant mortality rates by time. Let me draw your attention to the red line, which is essentially the post-neonatal infant mortality rates for white babies. And from 1946 to 74, you can see that there's a downward trend, which is not surprising. We know that, there's been broad improvements in various health indicators, and this is one of them. Now, what's interesting, though, is you pay attention to this green line, which are essentially African-American babies in Illinois. You can see that in 1946, there's a disparity. It appears to widen a little bit up till 1965, and then there's an inflection point with a downward trend. If we take another example, Mississippi, which is the blue line, you can see that the disparity is not only greater in 1946, but it widens considerably up to 1965. But again, there's a sharp decline. And he attributes this decline to the advent of the civil rights legislations, right? That especially with the desegregation of hospitals, we see marked improvements in health outcomes such as these. We can look at some other work. So this is a graph from George Kaplan and colleagues, and this is life expectancy. And this is looking at the period before the decade before 1965, as well as the decade after 1965. And if you look at the bar chart for Black women, you can see that the increase in life expectancy was much greater after 1965 than before. For African-American men, there was actually a reduction in life expectancy in the decade before 65, but then an improvement afterwards, and also an improvement for white men and women, but certainly the improvements were much greater for the Black community than the white community. So this is all good, and you might say, wow, this is great. These civil rights interventions are really important, absolutely, and they do also show, spillover effects to improving health and well-being. Unfortunately, the picture doesn't seem that rosy when we take a longer-term view of these health inequalities. So this is some data where we're looking at the trends over time, and you can see that in the long run, we actually don't see the same market improvements that we saw in the shorter run slides that I gave you. You know, here we're going from 1900 to 2010, with the red band being the 1960s. And though you can see that there's definitely some improvement, the gap is reduced over time. It's not quite as severe as we saw on the other slide. And this is for overall life expectancy. But if we also take a look at a more focused indicator, such as what you're seeing here, you can see that, that for, sorry, my slide is going wonky. You can see that there's some improvement up till 1975 in heart disease disparities, but it begins to widen once again. And we may draw some insight from Derek Bell, who observed that even these Herculean efforts that we hail as successful will produce no more than temporary peaks of progress, short-lived victories that slide into irrelevance as racial patterns adapt in ways that maintain white dominance. And so what is going on here? It seems like there's some room for optimism, but then at the same time, if we look at other patterns, we maybe have more cause for pessimism. And I posit that what is going on is that much of the thoughts that we have had have really focused on institutional racism, but not structural racism. And the difference here is that institutional racism is really focused on the work of individual institutions like housing, policing, education, healthcare, but not looked at the structure of all these institutions as a whole. Now, let's first talk a little bit about institutional racism, and then I'll talk a little bit more about structural, and hopefully these distinctions will become a little bit more clear. Now, as many of you know, there's discrimination in housing, and an important aspect of discrimination regarding housing is the affordability. You know, most people cannot buy a home outright with cash, so of course they have to get a mortgage. Unfortunately, due to redlining policies by lending institutions like banks, many communities of color were not able to acquire, the capital that they need to buy a house, refinance, and so forth. And so Congress enacted the Home Mortgage Disclosure Act in 1975 in response to community concerns. What's important about the HMDA is that it actually is designed to collect data to monitor discrimination by lenders. So anybody today who's going to borrow money from the bank with regards to, say, a mortgage, the bank is required to ask about your race, about your gender, your income, and a few other things like that, so that we could actually detect whether that bank is discriminating against women and people of color, or even the whole banking industry. So you could actually go download the HMDA data and take a look to see what's going on. And so it's kind of looking at that insight where we're looking at the behavior of a single institution, banking, that we could maybe start to think about how institutions discriminate. And that was the basis of my dissertation that I published some many years ago, where I was looking at discrimination at multiple levels, discrimination from banking, also including segregation, as well as individual reports of discrimination, to try to think about this at a multi-level perspective. And certainly many others have been thinking about institutional discrimination perpetuated by, say, state policies and so forth. For example, the work of Mark Katzenbiller and many others. And others have thought about how institutions like the court system have contributed to many inequalities in health, as well as various other outcomes. And so not surprisingly, for example, given the rise of mass incarceration of African Americans and Latinos, people have dubbed it the new Jim Crow. The old Jim Crow actually never left us, but morphed out of residential segregation to essentially segregation of people into prisons. And as health researchers, we can start to estimate associations like that using our regular conventional, regression-based models. So we can look at, for example, how imprisonment is related to outcomes like mortality. The thing is, of course, the prison system is connected to the courts and to policing. It's connected to the education system. It's connected to employment and so forth. And so it's really this idea that many people, such as Barbara Reskin, has really talked about race as a system, and that we need to start thinking much more broadly away from institutions, but about the connections, the flow and exchange across these various institutions and organizations and how they work together. And others have mentioned this. So Zinzi Bailey, for example, says that structural racism is the totality of ways in which societies foster racial discrimination via mutually reinforcing systems reflected in history, culture, and interconnected institutions. And it's this key word of interconnections that I really want to focus our attention on today. Using Buckminster-Fullerene, or carbon-60, buckyballs. Essentially, this is a carbon atom shaped like a soccer ball. And as you may know, the chemists who discovered carbon-60 won a Nobel Prize. It's considered the fourth form of carbon. It's very strong, very durable, much like a soccer ball. And if you think of each carbon atom, those little black circles, as an institution, right? So each atom represents housing or healthcare or education, but they're all connected by these bonds. And now, if you think about a soccer ball, if you kick it, the ball momentarily deflects. There's a little, bump in the side of the ball, but milliseconds later, the ball reverts back to a sphere. And that's because the force exerted on any one single space of that atom, a molecule rather, gets distributed across the entire entity of the molecule. Same thing, I believe, with racism. When we have interventions on civil rights at specific institutions like medical care or housing, that's fine, it's great. It helps a little bit, but then the forces of racism gets distributed across the entire system, where the work of racism is taken up by another institution. And so I believe that's why, for example, in many situations, many of the acts of violence perpetuated by police officers, they are covered not only by other police officers, but by the court system, by other aspects of the criminal justice system that can take up some of the slack when individual officers, transgress boundaries. And so I think this is an analogy for how we might want to think about Derek Bell's initial epithet, where we basically said that, all these Herculean efforts inevitably revert back to the equilibrium of inequality that we have. And so for me, I think it's important for us to continue the work that we have towards looking at individual acts of discrimination, but also to continue the work of institutional racism and understanding what that is, because that area of work is still in its infancy, but also now start to move towards thinking about structural racism just as importantly. And so let me just give you some very preliminary thoughts on how we might start to do this. This is some work where they're using social network analysis to think about white supremacist networks on the internet. And so it's looking at which groups communicate to which other groups. And maybe not surprisingly, neo-Nazi groups are communicating with skinheads. But what's also interesting about this sociogram is that these movements are also connected to music and books, right? There is actually other stuff that is connecting social organizations, these interest groups, if you will, to other things that we might also value, such as books and music. Here's another study that was published a little bit more recently, looking at extremist groups in Italy. And you can see again, you see neo-Nazis and skinheads in the sociogram, but you also see publishers, political parties, music groups, and so forth. And so we might start to enlist the tools of social network analysis to look at the flow of information, money, communications, memorandums of understanding, both formal and informal, that connect these organizations together. And here's yet another analysis looking at hate speech on Twitter. Each little dot represents an individual person who's using Twitter, but that person is connected to a whole bunch of other people, and you can see that the tweets can be passed along and retweeted to others within that network. So the implications are that we can start to think about, from a research and intervention perspective, about thinking about multiple institutions at once, thinking about the flow of money, information, practices, and so forth across these institutions. And also I want to raise this idea of racialized rules. These are rules that help establish how we do work on an everyday basis that institutions kind of perpetuate across one another. This is also not a new idea. So for example, Eduardo Bonilla Silva has mentioned that racism provides the rules for perceiving and dealing with others. Chandra Ford has also talked about how our norms within science help reinforce existing racial and other hierarchies. And so these rules help us do the everyday business of establishing which groups should be on top and which groups should be on the bottom. So racial sorting. And let me give you a few examples of that. And I'll also talk about the pretty hot topic of racialized algorithms that I'm sure some of you are involved in today. So here is a screenshot taken of something that we might pull from the Census Bureau, right? And this is just basic demographics, something that we see on an everyday basis. But the question I have for us is, how are these groups sorted? Are they listed alphabetically? No. Are they listed by population size? No. Are they listed by which groups were on this land first? No. I believe that this is sorted based on implied notions of which groups matter to us as an American community. So whites are literally on top, followed by African Americans, American Indians, Asians, Native Hawaiians, and Pacific Islanders, and some other race. So in discussions, in thinking about race, I think this is ordered by which groups we would like to think about preferentially, because it's not sorted alphabetically or by population size. Here's another example, taken from a research article I just pulled randomly from AJPH. And again, you see a very predictable ordering, right? So we begin with whites, then non-Hispanic Blacks, Hispanics, Asians, and others. And again, it's not sorted by sample size. It's not sorted alphabetically, and it's not even sorted by the vaccine uptake rate, but it's sorted again by this very predictable hierarchy that we have. It manifests in another way. So let me show you a graph, this bar chart, where I want to pay attention to the concordance between the title and the data. Okay. So the title says African Americans and Hispanics are most likely to be uninsured during the past year. And again, you can see that the two groups, according to the bar charts, that have the highest uninsurance rates are African Americans and Hispanics. And again, here you can see the concordance between, the title and the data. So you can see that Hispanics and African Americans are most likely to feel treated with disrespect. And again, if you look at the bar charts, it's those two groups of African Americans and Hispanics. But now take a look at this one, right? It says, sorry, I have to click on this because there's something weird about my Zoom that's going on. It says minorities are least confident, but the two groups that stick out are Hispanics and Asian Americans. If we were to use parallel sentence construction, the title of this slide should say Asian Americans and Hispanics are less confident they will receive good quality healthcare. And if we take a look at this next graph, the two groups that are the least satisfied with healthcare are Asian Americans and Hispanics. But the title doesn't say anything about any disparity group. So this is really important, right? Asians, in this case, when they are the worst off group, are rendered almost literally invisible. Here's another example, using data from the EPIC study of about 50 million COVID patients. You can see that the accompanying text says overall Black, Hispanic, and Asian patients had significantly higher rates of infection compared to whites, and the bar charts kind of, comport with that data. But again, if you look at, the next slide, this is hospitalization and death amongst EPIC patients, and the group that has the highest rates are the Asians. But if you look at the accompanying text, it says people of color. So this is really important because, again, this goes back to the implied notions of which are the disparity groups that we pay attention to. I have a lot of students that come to me and say, Gil, what do I do? I'm interested in studying Asian Americans. How do I get the data? There's no data for us. And I tell them, look at the tables. Because in the tables, we are sometimes there, but we are rendered invisible if you only read the text. So this goes back to these racialized rules of everyday business, of constructing table 1 about how we order these groups. And we do this across multiple institutions. This is not just the purview of the Census Bureau or of those of us producing health statistics or those of us people working in criminology and education and so forth. We do these same practices of racial sorting across all of our day-to-day practices. And I'm guilty of this too, by the way. Now, I want to switch gears a little bit and talk about racialized algorithms as another way that institutions kind of perpetuate bias and discrimination. Certainly, it's a hot topic right now. This came about, with a piece that came out in the New England Journal of Medicine this past year about many of the correction factors that we have in cardiology, oncology, endocrinology, and so forth. Basically calling into question the standard practice that we have to adjust the values of various metrics that we have in order to do good things. I mean, the idea behind it today is to improve clinical care and have more accurate data. But the problem with these algorithms is they actually have a very racist history. And a good example of this comes from the book by Lundy Braun, Breathing Race into the Machine, where she talked about the history of spirometry, right? So this is, you breathe into a machine that, looks at your, the volume, the capacity of your lungs to expel air. And we can look at these spirometers, and in the user's manual, there's a correction factor. So for example, here, there's an African ethnic correction factor of 0.88. So if the patient is African American, you input their race, you input, whatever other values are there, and the data that are spit out are automatically corrected for you, whether you want it to be corrected or not. Now, the issue here is, and as pointed out by that article in the New England Journal of Medicine and many other articles, is that these data are not necessarily the best data that we have. They're not actually necessarily based on really good science, and they're also based on a very racist history. And let me review some of this latter points to you. So in 1851, a physician named Samuel Cartwright wrote, and I have to excuse some of the ideas here, is that it's not only in the skin that a difference of color exists between the Negro and the white man, but in the membranes, the muscles, the tendons, and all the fluids and secretions. The reason for this is founded on unalterable physiological laws. So basically what he's saying is that black-white differences are not environmental in origin. They're based in our basic biology, and that they're not changeable. Okay. And what's also important about Samuel Cartwright was he was not a kook. You know, his ideas, he's important because he actually was a prolific writer, but he was also part of the medical mainstream in many ways. Moreover, the work of this was not just documenting and stating race differences, but actually to justify slavery. He wrote, under the compulsive power of the white man, they, as in, Negroes using his term, are made to labor or exercise, which makes the lungs perform the duty of vitalizing the blood more perfectly. And this goes to the idea that people of African descent would ultimately degenerate and kill themselves off if it were not for the beneficence of their white slave masters and the exercise that slavery allowed them to perform. And it's because of slavery, right? This is all twisted logic, right? But slavery actually helped improve the well-being of the, of Black slaves, because otherwise they would just kill themselves off. And so it's because of slavery that they actually lived longer. And hence we are concerned with things like vitalizing the blood, looking at breath volume and things like that, using tools such as spirometry. And we saw this not only emerge in our medical thinking, but also in statistical thinking. And so, for example, there was an article published in JAMA in relation to the Tuskegee syphilis study, where they start to talk about how we have these lessened threshold values for symptoms. And so now you can start to think statistically, right? Now you're thinking inflection points, we have a curve and there's a deviation from the curve. So all these things are starting to come together into much of the science that we do today. And in fact, we have these correction factors for various metabolites like creatinine. So here's an article that was written where we're looking at data from N. Haynes to try to correct for race and gender. And in this article, I want to point out some of the text that they used to talk about these correction factors. And so to quote, a racial correction factor is introduced to account for the higher lean body mass and creatinine excretion rate of non-Hispanic Black patients, but no factor, if needed, is available for other N. Haynes ethnicity groupings, for example, Mexican American and other Hispanic adults and children. Ethnicity, like race, is self-reported and alone is not expected to have a major influence on musculature. Now think about this for a second. It's really crazy. The writing is awful, right? Just from a literary standpoint. But, they're kind of going back and forth, right? They're saying, well, we're correcting for, Black people in Haynes because they have a higher lean body mass. But you know what? Like ethnicity and race are both self-reported, and we're not going to do this for Hispanics, because ethnicity is not going to influence musculature. But so it's kind of, they're trying to have it both ways. I think this convoluted writing is because the authors themselves realize that there's a contradiction here. So they can't figure out a way conceptually to justify why they're correcting for African-American race, but not correcting for Mexican-American ethnicity. We hide behind how Directive 15 makes an arbitrary distinction between race and ethnicity. So we just kind of hand wave and say, well, we're doing it for Black estimates, but we're not doing it for Hispanic estimates. And our discomfort with this whole notion will translate into the discomfort that we exhibit in our writing. Interestingly enough, of course, these correction factors are put into the tables. they make their way into our research. And so here's one of their tables. And of course, this 0.18b is the correction factor for a Black participant. So, you can estimate all these things and produce data all you want. But, here, what's important about this kind of justification for these racial correction factors is really no understanding that there's this whole history behind why some of the research uses racial correction factors, and no understanding on what we might want to do today to kind of get us out of these conundrums. Okay. This makes its way into not only other literatures, but across the globe. So let me read to you some texts from some research on brain atlases. So essentially, right, as many of you know, your brain is a three-dimensional object. And if you have to go in and do, surgery in your brain, or, want to look at various things that are happening there, you really need to pinpoint in this three-dimensional space where in the brain you want it to be. So we create these brain atlases, much like we create Cartesian atlases for, trying to figure out how to get to Seattle. And one of the things that's happening in the literature, of course, is that many of the brain atlases were developed for Western populations. And so here's some research where they were saying genetics and environmental factors make the Oriental and Occidental populations dissimilar. Thus, using Caucasian atlases for Chinese populations leads to overall brain volume, shape, and size differences. Essentially, what they're saying is that to use a Caucasian brain atlas for Chinese people is fraught with danger, because you're going to end up in the wrong place in the brain if you're trying to figure things out. So we need to essentially create a brain atlas for Chinese populations. And if you thought that this was maybe published, 100 years ago or 200 years ago, you would be forgiven, but this was published only 10 years ago in NeuroImage. But more importantly is the justification that these Chinese authors have used. Thus, if Caucasian-based brain atlases are employed as a reference template in Oriental neuroimaging studies, some bias may be observed that are driven by intrinsic differences between these two cohorts. So the assumption here is that any differences we see between Chinese populations and Caucasian populations are driven by intrinsic biological differences, which is exactly the kind of language that people like Samuel Cartwright used. And so, those of us who are worried, about the suicide sciences that came about, a couple hundred years ago, where we would read bumps on our heads to try to infer differences in IQ and constitution and so forth. The language and some of the ideas are still abound today. And don't get me wrong, I'm not saying that we shouldn't be doing any of the kinds of research that people are doing and investigating all the various differences that we have across populations. But we should be very cognizant of the assumptions that we're making about what drives these differences, and rather assume what is making up these differences, actually start to investigate the various hypotheses that are driving them, and to understand the history of where these ideas are coming from, and not take them as granted. Okay. All right, so this issue of these correction factors, whether we're correcting brain atlases, correcting our SAS code, correcting a bunch of other things, metabolite values and so forth, these algorithms are seen in so many of our industries, practices, disciplines, fields, and so forth. We use racialized algorithms in face recognition software, in clinical practice, in research, in predictive policing, targeted advertising, credits buildings, judicial awards, and so forth. These algorithms are everywhere. It's talked about in a really nice book called Algorithms of Oppression by Sophia Noble. You could even do this today. So I went to Google Image yesterday, and I typed in the word professor. What's the common denominator here? Right, this probably doesn't represent many of the people on this webinar. It certainly doesn't represent me. And so, a child who's going in and say, oh, I want to be a professor, let me type in, what we might get. Well, these algorithms, these search engines, return to us, data that are biased in certain ways that we may or may not recognize. Okay. And in fact, you've probably seen this really nice piece by Obermeyer in Science talking about racial bias in algorithms used in a health care system where they were trying to estimate, capture patients for triage to improve their care, and the algorithm was biased against Black patients simply because the algorithm was estimating based on the cost of patients rather than actual disease. And once they actually reran the algorithms, they rewrote them and said, well, instead of estimating on cost, we're going to estimate on actual severity of disease. The racial bias disappeared. And the reason was that Black patients in their system actually cost less. And so that was part of the reason for the changes in what they're finding. So let me start to connect some of the dots. And in order to do so, I want to go back again in history and talk about some work by Frederick Kaufman, who was a statistician for Prudential, the health insurance company. What's remarkable is in 1896, he wrote a 300-page book on racial traits and tendencies of the American Negro. And it was kind of a really amazing compendium, if you think about it, because, they got data from the census, they estimated, mortality statistics. And remember, this is in the 1800s. We did not have supercomputers. We didn't even have vacuum tubes and cards, right? This all had to be manually calculated. 300 pages of calculations of stuff like this. And they also calculated, essentially what we today would call SES, and they looked at the value of land and buildings by race. And they also looked at other groups like American Indians, Hawaiians, Maoris, and so forth. So in many ways, it's a remarkable body of work, all done by hand, at the behest of an insurance agency. Now, unfortunately, the work was not so benign, because one of the problems that Prudential was facing was they realized that, wow, our Black policyholders were dying earlier than our white policyholders. They're costing us money. So what Prudential did was they issued this revision to their claims policy. And they wrote this: the sum payment assured will be 1/3 less than now granted for the same weekly premium. These changes are made in consequence of the excess mortality in the class above named, i.e. Blacks, but they do not apply to other persons. Okay, so in other words, if you are a Black policyholder at Prudential, we're going to pay you 1/3 less than what we previously paid you, but they don't apply to the white policyholders. Okay, and the reason we're doing this is because we did all these statistical calculations, and unfortunately, we're just losing money. Okay. So what's important here is this integration of science, of statistics, of race, in order to enact economic inequalities. We continue to do this today. And so imagine this scenario. And don't read this just yet, but let me just kind of set this up, right? So imagine that 2 children die in a car crash, and you're estimating out the payout to the family of the survivors, right? So how much do we pay to the families for the loss of this child? So what they conventionally do is they, hire an actuarial and they say, okay, well, assuming that this child lives to age 65, their lifetime earnings will be, let's say, $1 million. Okay. Now, those are assuming that the child was a white boy. Okay. Now, imagine that, well, it's a girl. Well, if it's a girl, on average, women make 75 cents to the dollar. So instead of paying $1 million, we should do a correction factor for gender. Because women are expected to make 75 cents, then we should only pay out $750,000. So, and if it's a Black girl, well, maybe it's 65% of the earnings expected of a man, so we'll pay out $650,000. So this is essentially what happens on a real, on a day-to-day basis in many courts. They adjust the payouts based on gender and race. And so there was a survey of forensic economists, and they asked them, if you're estimating the loss of a 2-year-old African-American boy, what data would you use to estimate this? And half of them would use gender-specific data. Only 0.5% would use race-specific data, but actually about 44% would use both, and 8% would not use any such race or gender correction. And the justification in some of the qualitative parts, one of the economists said, it's our role to be scientists and to use the best available data. To fail to use gender and race-specific data is to make political correctness more important than science. But that was not the only view of these economists. Another person said, I would only use the data for white males, as they are the only cohort that did not suffer any past gender or race bias in hiring, and consequently not continue the impact of such bias. Right. And so many of us today, we understand that, wow, there's disparities in wealth and income and so forth. And some of this actually happens in the courts through these compensations. And this is some data that came from some work in the Washington Post. They've done a nice series of articles on these, judicial rulings and how they're unfair, essentially by gender and race. And I won't go into that. So I'm going to start to close this up because I know we're starting to run out of time. In thinking about structural racism, we are thinking about not only the connections across institutions, but the rules and practices that they share in common, right? And so we have a rule implied that these correction factors are necessary in medicine and research and court settlements, and they're standard practice. So we should continue to do what we've continued to do. But of course, that comes from a history that we today probably wouldn't agree with. We use these in estimating various things that we use in health, but we also use in courts and so forth. They ultimately end up in perpetuating various inequalities that we have. And so these algorithms reinforce the idea that race is intrinsic rather than socio-political. Many people have said, of course, that race is a social construct. I start to take the idea that race is a political label, because I think saying race is a social construct, we've said it so often, it just kind of goes over our head. We don't even think about what that means anymore. But once you start to say, race is a political label, then it makes people think, maybe we really need to, is that true? Should we interrogate this further? If it's a political label, then do we need correction factors for Democrats versus Republicans in Haynes data? I don't know. I'll let you tell me about that. But these ideas are evident in many fields, and comes back to this idea of thinking about race, structural racism, as the totality of systems that perpetuates inequalities. And even this model of Buckminster-Fullerene is still too simple. We could even get more complicated into endohedral fullerenes, which of course are even way more complicated. And as a bonus fun fact, It's very interesting that these fullerenes are the second most expensive product on the planet. The only thing that's more expensive than fullerenes, specialized fullerenes, are black matter. So some of these ideas are in an article that Maggie Hicken and I put together on behalf of NIMHD. So I want to thank them for that special issue, and I want to thank you for your time and welcome your questions.
Dr. G, thank you so very much for the very informative presentation, and also to some extent heartbreaking to learn about, this is not something that is, I mean, something that's new to some of us, at the same time something some of us have endured for a time that we have, living in this country. A few questions came through the chat, and I would pose it to you, Dr. G. One of the questions that came is talking about, in general, the society value the white population seem to more than other groups, and that not only, sometimes even among the minority groups have that kind of perceptions. And how does that actually, that overall culture influence the decision of scientists, researchers, and scientific decision makers?
Sorry, can you repeat the question one more time?
Yeah, I think the overall idea is that, that the tendency of favoring the white population, that kind of mentality, how does it affect science? How does it affect scientists and researchers when they do their work? And how does that affect some of the scientific decisions being made?
Oh, it affects us. I'll give you a few examples. So probably many of you have sat through review panels where reviewers are asking, hey, here's a study of a single race group, African Americans only. Where's the white comparison group? Right. So just kind of mandating that we have a white comparison group. In many studies, if you, for example, many of you are probably familiar with James Jackson, and as he was setting up many of his work, they talked a lot about the struggles of trying to get an African American only cohort study. So do we really need a white comparison group for a lot of the research that we do? Secondly, in not only setting up studies, but in publishing articles and whatnot, I've seen that struggle happen. Also, I was an editor-in-chief of a journal, of a scientific journal, and I saw that in peer review. That's one example of it. It also happens when we start thinking about which is the reference group that we should use when we're estimating, rate ratios and things like that. And, of course, sometimes you use the larger sample, and that oftentimes happens to be the white sample, and that can make sense. But a lot of times it happens because this is the sample that we think of as the norm, right? If you think worldwide, Caucasians are actually in some ways the minority across the globe, right? If you think about, which countries have the most populous communities, you would probably be thinking Asia, right? Both India and China have, over 1 billion people. And so they account for something like 2/5 or maybe 3/5 of the world's population. So if we really want to think about, hey, there's universal human processes, then, and if you take as your point of view the most populous group, then you might want to start shifting how you want to think about this. Or you might want to think, hey, if a lot of our origins of humanity are coming from Africa, maybe we should start to shift our reference group to thinking about, well, relative to the African population, how might our estimates differ? So, it plays itself out in subtle ways on reference groups and things like that. Which groups are considered the norm? When we start talking about correction factors, we're not talking about a white correction factor ever, right? It's always some minority group that is deviant, and we have to correction for that deviance.
Right. I think that's very, very well put. The other question is about, and came from the audience, that, the lack of understanding of race as a social category, as a form of structural racism, and specifically in our day-to-day interaction in our encounter with various social institutions, and how might we go about examining this empirically?
Wait, say that last part again, or say that question again.
So I think the questions that was asking, how do we examine empirically that the lack of understanding of race as a social category may be a structural racism itself? And how do we look at the impact of that, lack of understanding empirically and affecting the science and health?
Yeah, well, I think there's a lot of things we can do, right? So one is we should, at the most fundamental level, just as good scientists, just ask all the plausible reasons for any observed race differences that we see, no matter what the research we're doing, whether we're working in the neuroimaging space or whether we're working in the metabolite space or cardiology, whatever it is, ask the fundamental question of what are all the plausible reasons for these race differences, and not only assume that they are biological. And again, this goes back to saying, hey, race is a political label. If we say that race is a political label, it directs us towards thinking about other explanations that may be more that are related to racism. We can start to build more methods for studying structural racism, and I know there's an RFA out on that. And so we need to start building more tools. I think we do need more examples. We need more textbooks. In the work that I do, we have a few standard textbooks, but most of the textbooks are still building from ideas where, we're really trying to, where the textbooks were not designed and the theoretical models were not designed to study inequality. And so as an example, I tell my students, the health belief model says nothing about disparity. So how can you jerry-rig the health belief model to talk about racial inequalities? You probably can't. You might have to start with different models. And then I think if we are talking about structural racism and that its connections across institutions, we need to facilitate the ability to look at data across institutions. I know there's a lot of barriers that are both put in place to safeguard privacy and confidentiality as well, and those are certainly important, but we also have to find ways to make it easier for researchers to actually do the work across these institutions, to do data sharing between the Department of Transportation and DHHS, for example, so that we could do even better studies of place and health, much less race, place, and health. So does that help a little?
Right. Yeah, I think that's a tough question, and there's certainly a lot of ways that we need to improve upon to address this issue. And one of the questions that came in is about how do any of this impact or influence or relate to those who are biracial, and I would also put it multiracial individuals, right? As the multiracial individuals are actually growing in the United States population, how does that impact those folks?
Oh, wow, that's a huge one. And the reality is many more people are bi and multiracial than we would like to assume. When we talk about the one-drop rule for African Americans, that implies that many African Americans are more biracial than we would like to assume. If we look at somebody like Tiger Woods, he calls himself Kablan Asian, right? Tiger Woods identifies Kablan Asian, Caucasian, Black, Indian Asian, right? What do we do, right? I think we don't yet have a consensus what to do about multiracial, biracial communities. We have a few decision rules here that people, I think, do more or less on an individual basis, like we'll just put them into other. But we really haven't thought of a way to think about that complexity. We really don't even have a good science for heterogeneity. So for example, Asian Americans and Latinos for many years have said we need to look at heterogeneity within our communities, disaggregate and so forth. We're starting to do some of that now, but we don't actually have a good theory of heterogeneity. And that's also true for white communities as well, and for African American communities. So, we lump people from Russia alongside people from Ireland and the Middle East. Does that really make a lot of sense? So there's definitely a lot of more work to do, and I know that there's a lot of bright minds out there in this audience, and I'd love to hear what people are saying about that.
Yeah, that certainly is. I think you touched on some very good points. And the multiracial population has always been here. It's just that there not been a systematic way to actually have them being recognized and being also tabulated in our statistics. And oftentimes they become the other group, and they have been others for many years. And even when we look at heterogeneity within so-called each of the racial ethnic population, they're certainly not the same. And this speaks back to the point that when you try to correct for those so-called correction by race, we are in some way extrapolating that mean differences, ignoring that the distribution within a particular racial, ethnic, or population group. And I think that certainly is not something that's wise to do. We're at time. We're at 11:30, and we have many more questions coming in. I apologize to all of you for not getting through those questions. And we'll try to see if we can post some of the questions to Dr. G if he has time to address some of those briefly. I know he is very busy. And again, I thank all of you for participating in this lecture, and I thank especially Dr. G for talking to us today. The recording will be available online. So if you want to see an encore presentation, you can always go there and watch, and we'll make an announcement once it's ready. Thank you so very much for every one of you participating, and have a good rest of the summer.
Great.
Take care.
Thank you so much. Have a great day.
True.